Hello, friends. I'm back. Good evening. It's like having HDP nights. Today is the third day. I'm not sure whether I'll be able to finish today. Doesn't matter. We'll go on to part 4 tomorrow because I want to really deal this topic very slowly and elaborately because it's a very, very important topic. We all have learned over the last 3 days the pathogenesis, pathophysiology, and prediction of preeclampsia. Incidentally, as you can see, today is the 700th lecture I'm giving in my life, other than the lectures that I gave during the regular classes for undergraduates and postgraduates. And today I'm going to talk a very, very important aspect, that is the prevention and management of preeclampsia. We can prevent eclampsia and we must prevent eclampsia. But as far as preventing preeclampsia is concerned, it's been a Herculean task and it's been a vexed problem because we don't know the exact triggering factor for preeclampsia. However, people have not stopped their efforts to prevent it. There have been umpteen number of efforts, and today I'm going to elaborate each one of them and see how successful they have been, whether they are worth it all those aspects. So I don't want to waste time because the time is at premium. Let me straight away jump into the prevention of preeclampsia. Again, I'm quoting ACOG Practice Bulletin 2020. What it says is women should be educated about the signs and symptoms of preeclampsia. So they will notify their provider as soon as clinical manifestations occur. Yesterday, I was telling you the old fashion is the new fashion. After doing all sorts of predictive tests, ACOG has come back to the basics, that is history and clinical examination, that is measuring the blood pressure. So when history is very important and clinical examination is important, it is important for us to educate women about the signs and symptoms of preeclampsia so that they can come to us early and we can take care of them. There is no way we can actually predict as such. We have seen that. So it's only early detection still as far as preeclampsia is concerned. And the earlier you detect, better you manage them, better you follow them up, and we can give a positive or better outcome. Follow up high-risk women with more frequent office visit. Yesterday, I gave you a big list of high-risk women. In that, again, more high-risk and moderately high-risk. We have to follow them up more frequently. Maybe we have to call them sometimes every week in the third trimester. So what are the interventions that have been tried over the years? Losing pre-pregnancy weight is a very, very important step and a simple step. Yesterday, we saw that obesity is one of the high-risk factors. Obesity triggers diabetes. Diabetes is actually a cousin of hypertension. And all three of them together predispose preeclampsia. So losing weight before pregnancy. In fact, this is a very important step. Even in infertility, we say PCOS patients, they must lose weight. Then our drugs will act better. So here, losing weight, a simple measure itself is very important. It goes a long way in prevention. Not exceeding recommendations of gestational weight gain by National Academy of Medicine. Okay, you cannot lose weight pre-pregnancy, fine, but during pregnancy, you should not exceed recommendations of gestational weight gain. And roughly in whole of first trimester, it's 1 kg, and second and third trimester onwards, it is half kg per week. They should not increase their weight more than that. Of course, the optimum is the most difficult part in life. We want them to gain weight, but we don't want them to gain more weight. Reduce the chances of multiple gestation if IVF. Yesterday, again, I was talking, IVF is one of the risk factors. It acts through multiple placenta. Placenta is the root cause of pathogenesis of preeclampsia. Everything is connected. So if the lady is going for IVF, we must go for single embryo transfer. And as far as possible, we must try to have single pregnancy, single gestation, singleton pregnancy. Low dose aspirin. Yes, this has been there for now more than 2 to 3 decades. I'm going to talk in detail about that. So just let me mention that these are some of the interventions. Calcium. Again, lots of randomized control trials have been done in calcium. I'm going to talk elaborately about that. Antioxidants. Yesterday we saw the connection between the first phase of the disease and the second phase of the disease. The connection between them is oxidative stress. That's why antioxidants have been tried, and then whole lot of other things, cod liver oil and the fish and so many other things have been tried. Let us look at each one of them. Aspirin. This has been there for a long time. Cochrane database systematic review 2019 has clearly given us what is the exact role of aspirin, what are the benefits, what are the contraindications, what are the problems with aspirin. The meta-analysis of 74 trials involving more than 40,000 women reported reduction. That's why I put it in green. By now, all of you must have realized my theme of colors. When I say something is high, severe, dangerous, I put red color. And when it is positive, good, favorable things, I put green color. And rest of the highlights will be in the brown color. So reduction in proteinuric preeclampsia. Okay, but we have not been able to totally overcome it. Just a reduction. Fetal or neonatal death. So if you have not conquered preeclampsia, at least you could reduce the fetal or neonatal death. Overall preterm birth less than 37 weeks is also been reduced. So we have been able to achieve term in these patients by using aspirin. Small for gestational age infants. So if you could at least achieve this much, that is good. So FGR is reduced. Composite serious adverse maternal and neonatal outcomes. So in other words, everything is thumbs up. Reduce preeclampsia, reduce neonatal or fetal deaths, reduce preterm births, reduce FGR, reduce composite serious adverse maternal outcomes. So aspirin is good, is proven. But what are the concerns with aspirin? Again, I'm quoting the same Cochrane database systematic review 2019. The intervention may slightly increase the risk of PPH. Slightly increase the risk of PPH. That is exactly why we stop aspirin around 36 weeks now. Earlier, when I was PG, when I was a junior faculty, I used to say we should stop at 34 weeks because we were worried about the patent ductal arteriosus. That is not the worry. The worry is about PPH. That's why we stop around 36, 37 weeks, at least 1 week before the delivery. Like in any other situation, 1 week before the surgery, 1 week before the dental extraction, we stop the aspirin. Similarly here, at least 1 week before the delivery, it is advisable to stop aspirin because there's a slightly increased PPH has been reported. But it did not have statistically significant effect on risk of abruption. So yes, aspirin, we know that it will cause bleeding, but thankfully, abruption did not increase. The bleeding that occurs between the placenta and the uterine wall did not increase. PPH was slightly increased, but not this. Little or no difference in the risk of HELLP syndrome, several maternal morbidity or NICU admission, severe maternal morbidity or NICU admissions. So again, thankfully, there was little or no difference in the risk of HELLP syndrome, severe maternal morbidity, or NICU admissions. No large or clear reduction in preterm birth. Yes, in the previous slide, we said there is slightly reduction in the previous preterm birth, but it was not really big enough to claim that give 100 out of 100 for aspirin. Yes, aspirin, we can give distinction, but not 100 out of 100. Aspirin to whom? That is very important. Yes, aspirin is good, beneficial, it helps, but to whom we should give? The greatest benefit appears to be in women at moderate to high risk of developing the disease, not the ordinary risk. Only those who are at high risk and moderate risk, we refer to my yesterday's class, they will be benefited by aspirin, not the usual risk. The risk I showed in 4 to 5 slides. Out of that, I selected again a few for as high risk or moderate risk. Those are the ones who will be benefited by this. High risk multiparous patients with no history of preeclampsia. So in the high risk of preeclampsia, we first was, if you remember yesterday, one who herself had preeclampsia. But this point is telling, even if she didn't have preeclampsia in her previous pregnancy, but now she's multiparous, but she has got high risk factors. Maybe she has got age not in her favor. So such patients may be benefited. High risk as per algorithms. So there is a big, beautiful algorithm which will tell us these are the high risk patients for preeclampsia. In Justosis talks, you will hear these algorithms, and those are the patients who will be benefited by aspirin. What about starting aspirin after you diagnose preeclampsia? This is a very, very important question. Whether it will still reduce the severity, whether it will help at all, because now we are not talking about prevention of preeclampsia by aspirin, because we have already diagnosed preeclampsia. Please read this carefully. Aspirin after preeclampsia, whether it is still beneficial. Low dose aspirin appears to be of little or no benefit in women who already have developed preeclampsia. So you can do more harm maybe because they may go in for bleeding and other things. So once you diagnose preeclampsia, there is no point in giving aspirin. Please understand this clearly. I'm going to repeat one more time. Once preeclampsia has been diagnosed, there is no point in starting aspirin. At this late stage, aspirin does not prevent progression to more severe disease and may exacerbate bleeding in patients with thrombocytopenia related to preeclampsia and HELLP syndrome. So not only it does not help, it can do more harm. That's what I told you. Because in preeclampsia, you know that there is deficiency in the platelets and there is a tendency for thrombocytopenia related bleeding. That will be enhanced because we all know that aspirin itself is going to hamper the platelet aggregation and things like that. So that's exactly why once you diagnose preeclampsia, please don't start aspirin. I want to give this message very clearly. What is the timing of aspirin? There have been lots of studies, and what we have gone by is what we just heard from Mandeep, who came and gave a lecture to us. It can be anything between 81 to 150 milligrams. It can be given morning or at night. No actually consensus in this. The Cochrane database always gives sometimes lopsided view or sometimes gives an ambiguous view. Start before rather than after 20 weeks. That's very clear. We must start before 20 weeks. As I said, most of the time the diagnosis is made only after 20 weeks. Even though preeclampsia pathology has been there before 20 weeks, we diagnose preeclampsia usually after 20 weeks. And if at all you reap any benefits, it should be before that. In fact, much before. If you have understood my yesterday and day before yesterday's talks clearly, the preeclampsia pathogenesis starts right in the first trimester. So in all high-risk patients, it makes sense to start aspirin at that time. At or after 12 weeks of gestation and ideally prior to 16 weeks. That's exactly what I told you 1 minute ago. If at all you want to start aspirin, you start aspirin very, very early, before 16 weeks. Otherwise, there is no point. That is why I told you yesterday, in Manipal, we are doing the prediction test with all that during the dual test time. When we do the dual test is usually done between 11.4, that is, let's roughly say it as 12 weeks to 14 weeks. And you will get a report whether she's high risk or low risk when we are doing PAP-A plus placental growth factor and all other factors that we consider high risk factors, her blood pressure and everything. So you get a report. And as soon as you get the report, if you find out that she's got high risk for preeclampsia, better to start as early as 13 weeks, 14 weeks, or whenever you have done the test, before 16 weeks. 11 to 14 weeks is the best time as per FIGO and Aspirin trials. Stop at 36 weeks. That's what I told you just a couple of minutes ago, that if you continue till delivery, right, the chance of postpartum hemorrhage is slightly more. You don't have to stop at 34 weeks like we used to do in the past. You can take up to 36 weeks, or at least, I told you 1 week before. Here you can see 10 days before delivery. If 10 is days, you please take it as days, 10 days before delivery. But however, there is no consensus. Safer to stop at least 1 week before anticipated delivery. So that's about the aspirin. Now let me turn my attention towards calcium. WHO says 1,500 to 2,000 milligrams of elemental calcium per day. Now the question is, most of the ladies find it extremely difficult to take calcium tablet, even a 500 milligram tablet. Either they say that the tablet size is very big. That's why some companies have come up with the smaller tablets and things like that. As I told you in another talk, jokingly, that we don't mind eating food every single day, 3 times a day or 4 times a day. But the moment it is a tablet, we don't want to take it. That is the mental block that we have. Chocolate every day, yes. Peppermint every day, yes. Food every day, yes. Tablet every day, no. That is the attitude all of us have. I don't want to single out anybody on earth. All of us feel that swallowing a tablet every day is not acceptable. But during pregnancy, you have to take iron and calcium tablet. There's no other go. And in fact, you have to take folic acid as well. Maybe in the first trimester, it's extremely difficult, though it is not contraindicated. First trimester, as it is, there is nausea, vomiting, you will not be able to take. But in the second trimester onwards, this should be taken. Calcium is so beneficial. Apart from other things, it prevents sometimes, it is been proven, but sometimes it is gone into controversy. But whatever it is, WHO is recommending 1,500 to 2,000 milligrams of elemental calcium in populations with low calcium intake to reduce the risk of preeclampsia, particularly those at high risk of developing hypertension. This is based on 2018 systematic review of 27 randomized trials, including 18,000 pregnant women. 1,000 milligram per day in pregnant women as per the Preeclampsia Prevention Up to Date October 2020. Now, if you cannot take 1,000 milligrams, you have to supplement it with either dairy products or with milk or with curds or whatever it is. Somehow you should make sure that you are taking 1,000 milligrams of calcium every day. What about others? After aspirin and calcium, there are a whole lot of things they claim that it is going to prevent preeclampsia. Low molecular weight heparin. Available data do not conclusively support use of prophylaxis in addition to low dose aspirin. People thought of this because in APLA syndrome, you start both aspirin and low molecular weight heparin. It may be okay if the patient has got APLA positive, but just in a general population or even in other high-risk population, if she is not APLA positive, there is no need to start heparin, low molecular heparin, because the data does not support that. Statins are currently contraindicated in pregnancy because statin, I don't know, I should not be talking against or for any drugs, but we know statins have been sold like peppermint or chocolate. Everybody is taking statins. The moment you become adult, you start taking statins because it's been so much pushed and promoted. But let me tell you very clearly, do not start statins. It is contraindicated in pregnancy. How about vitamin C and vitamin E supplements? Because they are antioxidants. Because we said oxidative stress causes preeclampsia, but they are not recommended as such to prevent preeclampsia. Let me qualify my statement. But vitamin C and E supplements are definitely okay during pregnancy because vitamin C helps in the absorption of iron and vitamin E helps in taking care of a whole lot of ailments, including joint pains here and there. Vitamin D supplements may reduce the risk of the preterm labor as well as preeclampsia. But again, let me tell you that taking tablets every day is not acceptable to women. You can give them supplements maybe at least once in a way, alternate days and things like that. Folic acid may not reduce or increase the risk of preeclampsia. Folic acid is good during pregnancy for other things, but it may not prevent preeclampsia. That's the meaning of it. Fish oil supplements, I was just talking a few minutes ago about fish oil and other things, showed a trend towards reduction in preeclampsia, but the evidence is of low quality. First of all, eating fish fry and other things may be very tasty, but fish oil, I'm not sure whether people would like it. But anyway, if it is nicely capsulated with all the aroma and other things, probably they may accept it. Nitric oxide donors, L-arginine systematic review concluded that there is no high quality evidence that administration of nitric oxide donors prevent preeclampsia. The idea was that it will do vasodilatation. That's why they thought it could prevent preeclampsia, but there is no high quality evidence. See how people have tried all sorts of things. That simply means even though we have understood what happens, but the treatment is not really is helping. So that's why we need to still explore. There is something that we are missing. Antihypertensive drugs did not reduce the frequency of preeclampsia or improve the fetal or pregnancy outcome. However, therapy did decrease the incidence of moderate to severe hypertension. What it means is starting antihypertensives at a very low, BP, like 140/90. Even though the CHIPS trial told that you can start, I'm going to talk more about it when I talk about the management of preeclampsia. Whether to start it routinely in everybody with the intention to prevent preeclampsia, it's not very clear because it did not improve any fetal or maternal outcomes. However, there was a slight reduction in the incidence of severe hypertension by using antihypertensives. Diet is the favorite topic of all the patients, all the doctors. Everybody wants to talk about diet. So what about diet? No beneficial results have been demonstrated from dietary interventions. So all of them are actually Cochrane database. You are not able to see the Cochrane logo, which is hidden behind my smaller window, picture-in-picture window. Protein and energy supplements have been tried because protein is lost during preeclampsia. People have tried that. Protein and energy restriction in obese women because they thought obesity will cause preeclampsia. Magnesium supplement, most of the companies come out and say that our tablet also contains magnesium because it will prevent. Salt restriction. This is one of the favorite things of all the people, whether you are having preeclampsia or hypertension. They say don't take pickles, don't take this and that. But salt restriction, yes, helps in a moderate way, but it's not going to help in a big way. So no beneficial results by diet modifications. What about behavioral changes? Of course, this is always welcome. Behavioral change is always welcome. So behavioral changes, there is no strong evidence that exercise and physical activity affect the risk of developing preeclampsia. Behavioral changes are welcome, but there's no strong evidence that exercise and physical activity affect the risk of developing preeclampsia. In fact, I guided a PhD on the role of yoga therapy in reducing the stress, and that's how different aspects. But we found that yoga is not really going to decrease the blood pressure. It's going to give you a positive outlook and positive outcome. It may reduce slightly stress and other things, but it's not really going to prevent hypertension or preeclampsia. We have submitted the PhD as well. Now I come to the all important aspect. We have understood the pathogenesis, we have understood the pathophysiology, we have understood the predictive tests and the preventive aspects of it. Now, when all that has not really worked well for us, finally we are faced with the problem, and that is preeclampsia staring at you. We have to manage. We have to manage somehow. So the management of preeclampsia is a balancing act. It's a tightrope walk. In fact, all management in obstetrics is a tightrope walk, because we have to balance between the maternal and fetal health. At the same time, we are tackling two lives. That's exactly why I feel obstetricians are, really strong and good in making decisions, because they make decisions for two lives at a time, and they make better managers, and they make better leaders and decision makers, according to me. The best care for mother may result in FGR. Best care for fetus may place the mother at risk. So you can't err on the side of mother. You can't err on the side of baby. You want both. So perfect timing is most important in preeclampsia, especially in our obstetric decision making. So management can be summarized in just 3 points. Number one, control of hypertension by using antihypertensives. Because that is the one, hypertension is the one which creates all sorts of problems. Pathology is all right, pathophysiology is all right, everything is all right, but ultimately it's the hypertension which is going to cause hemorrhage, which is going to push the blood out of the porous vessels, which is deficient endothelium. So unless we control the hypertension, the patient is going to have calamity. Second one, prevention of eclampsia by using anticonvulsives. I just in the beginning of the class today, I said preeclampsia is not preventable, but you have to prevent eclampsia at any cost. That is preventable. So that's the second part of the management. And finally, whatever you do, preeclampsia won't go away. I told you day before yesterday, preeclampsia is not just hypertension. Preeclampsia is a multi-organ disorder. It's a systemic disorder. It's a vascular disorder where the whole thing started because of placenta. And unless you get rid of placenta, you cannot get rid of preeclampsia. You may control hypertension, you may prevent convulsion, but if you want to get rid of preeclampsia, you have to deliver. That's the ultimate and definitive management. The first two are only to buy time till such a time when we are comfortable delivering her, because you want to give the baby a chance to live. We want to ensure lung maturity. We want to ensure neuroprophylaxis. That's why we want to take the pregnancy as far as possible to a stage where the delivery will not come in the way of baby's independent survival after birth. So delivery is the last or the ultimate treatment for preeclampsia. So let us take up one by one. I'm left with another few minutes only. Obviously, I won't be able to complete this today. I don't want to hurry up either. So I will go for part 4 tomorrow. I will go on as long as it is possible. So let me take up control of hypertension using antihypertensives. Now, it is very, very important for all of us to understand the management of hypertension in medicine. Internal medicine is totally different from management of hypertension in OBG. Many a times, this is not understood very nicely or clearly by physicians. We usually refer the case to physicians and they make fun of us, saying that OBG people do not know how to manage hypertension. And when they prescribe few things to us, we make fun of them by saying they simply do not know that these drugs are not acceptable during pregnancy. So that's why it is better we only understand how to control the hypertension during pregnancy. Our targets may be different. We don't want to hit the bullseye as shown here. Our target may be somewhere different. Why is that? We don't want a tight control of hypertension because, as I said, if you err on the side of mother, you will be hampering the baby. If you are on the side of baby, you will be hampering the mother's health. So if you bring down the blood pressure very low, then the baby will suffer. The hypertension, basically, all of us have some amount of hypertension, that is some amount of blood pressure, that is 120 by 180. Why do we have that? We have that blood pressure to ensure that our peripheral cells, tissues are nicely perfused. So if the blood pressure comes down drastically, baby is actually sitting in the tummy of the mother, all right. But if you go through the vessels, the baby is miles away from the mother's heart. So if the blood pressure goes down, baby will not get the blood supply. That's why we want the hypertension to be controlled for the mother's sake, but not so much that the baby suffers. I hope you understood. So we have to have a syndromic approach. Hypertension in association with thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, and new onset cerebral disturbances. We have to think of all these things while we try to control the hypertension. What are the principles? Number one, when to treat. This is a very important thing. What do you mean by this? At what level of hypertension you want to treat? Whether you want to treat at 140 by 90 level, or whether you want to wait till 100 diastolic, or whether you would treat only when it is more than that. Second question, how to treat, which means what to use and what to avoid. That's what I was trying to tell. Not all drugs can be used during pregnancy, especially the drugs that are physicians' favorite. They cannot be used during pregnancy. So let me talk about the levels. For this purpose, we can categorize the blood pressure only. I'm not talking about the preeclampsia. Preeclampsia, there is nothing like, mild, moderate, and severe. It is either preeclampsia or severe preeclampsia. As far as blood pressure is concerned, severe is 160 by 110. Moderate is 150 to 159 in the systolic, 100 to 109 in the diastolic. And mild is 140 to 150 in the systolic and 90 to 100 in the diastolic. There are too many numbers on the screen. So if I have to just single out three numbers, 110 diastolic, 100 diastolic, and 90 diastolic. When to start? So when it is severe, there is absolutely no doubt. Hypertensives, antihypertensives are always recommended because it is believed to reduce the risk of maternal stroke. So there is no doubt. The doubt is only when it is mild to moderate. Earlier, we used to say, don't start antihypertensives when it is mild. But let's see what's the recent thinking, mild to moderate. It is a prudent approach to considering patients' comorbidity and symptoms before we start treating. Just because the hypertension is 140 by 90, don't say there is no need to start antihypertensives. If she has headache, visual disturbance, and other comorbid symptoms, probably it is prudent to start antihypertensives even when the blood pressure is 140 by 90. And if you remember, other day I was telling, it's not just the absolute value. Yes, the modern definition says absolute value of 140/90. But it is always better to see the trend of the hypertension. If there has been a rise of 30 systolic and 15 diastolic, as in the old textbooks, definitely this patient probably requires antihypertensives. So you have to look at the big picture rather than just restrict yourself at the reading in the sphygmomanometer. The benefits and potential risk of treatment are less clear. That's exactly the problem is. What were the concerns? As I said, aggressive lowering or medication themselves inhibit the fetal growth and expose to harmful effects of the drugs. So when to start, whether to start at 90 or 100. This is a landmark trial, I can say, CHIPS trial, where they posed a question, not just 90, they posed a question to themselves whether to start at 85 or 100. Also, the meta-analysis, that is whether to give treatment or not to give treatment, done by Cochrane database in 2014, and also Webster et al. Told that maternal treatment did not increase the risk of FGR or cause excess fetal risk, which means we can definitely start antihypertensives, especially in the ladies who have got other comorbidities, even when the BP is 90. We don't have to wait, always wait. I would use the word always wait till it is 100. So that means there's no one size fits everybody. We have to individualize the treatment, which is the advice in every single disease. What are the benefits? Lower BP was associated with reduced occurrence of severe maternal hypertension during pregnancy. You are not able to read that reduced, it is in green. I told you whenever there is a favorable outcome, I put it in green. Also, we have to remember it did not result in less preeclampsia or maternal stroke, which I already told you when I talked about preventive measures. Starting antihypertensives is not going to reduce the preeclampsia part of it. It may reduce the severity of it. So that's exactly why we may start antihypertensives, but should not expect preeclampsia to become less. Overall safety, if I have to say, all antihypertensive drugs cross the placenta. So there are no data from large, well-designed randomized trials on which to base a strong recommendation for use of one drug over another drug. But we have to also remember that to add to this confusion, women with chronic hypertension, either treated or untreated, are at increased risk of cardiac malformation in offsprings compared with normotensive women. Maybe it's a similar risk factor, or it's antihypertensives which are the culprits. So we have to be very careful, especially when starting antihypertensives, giving antihypertensives in the first trimester. Whatever it is, few things are extremely clear. We have to avoid ACE inhibitors, ARBs, and direct renin inhibitors because they are associated with renal anomalies and FGR. Unfortunately, these are the favorites of physicians, but they are banned in OBG. Also, mineralocorticoid receptor antagonists